我也给你回我。
Okay, now you can see the screen well.
Yes,
Okay.
yes.
Okay. We will talk about the microwave ablation of bone tumors as a new player in the field of microwave ablation of tumors. Again, I'm Gamal Niazi, professor of body interventional radiology, Ain Shams University, Cairo, Egypt, and I would like to express my deep thanks and gratitude to the International Microwave Ablation Academy, to Canyon Medical, and to Medilab International for hosting this important webinar and for allowing me to share my team experience of 3 years of microwave ablation of bone tumors. What do we ablate by microwave? What types of bone tumors we ablate by microwave? We usually ablate osteoid osteoma, we ablate osteoblastoma, chondroblastoma, and metastasis. I have started thermal ablation of bone tumors in 2006. And all over 15 years, I was only doing radiofrequency ablation for bone tumors. And then, 3 to 4 years ago, I started to shift towards microwave ablation of bone tumors. And after 3 years, now I think we have good number of cases that will help us to publish and discuss our amazing results regarding the microwave ablation of bone tumors. The microwave electrodes used for ablation of bone tumors, we can use any type, any shape, any length of microwave electrodes, but the most commonly used electrodes for ablation of bone tumors are these two short length, light-weighted microwave electrodes, the 18 gauge, 7 centimeter length, 3 millimeter active tip electrode, and the 10 centimeter length, 16 gauge, 3 millimeter active tip electrode. I have now the microwave electrode. If you can see it, this very small, very light-weighted microwave electrode with a short length, 10 centimeter length or 7 centimeter length. Yes, the electrode that is commonly used for thyroid ablation. It could be also used for bone ablation. And the 3 millimeter active tip electrode with this very elegant shape of handle. And this will be very important as we will see and discuss in our illustrative cases. These are the most commonly used electrodes for ablation of bone tumors. As we said, we started in the late 2023. In early 2024 till now, 2026, we have performed about 64 cases of microwave ablation of bone tumors. 60 cases of osteoid osteoma, 1 case of chondroblastoma, and 3 cases of bone metastasis. Our cases were almost distributed all over the skeleton. We had like 29 cases in the femur, 17 cases in the tibia, 2 cases in the fibula, 1 case in the talus, 1 case in the metatarsal bone, 1 in the humerus, 2 cases in the radius, 3 in the scapula, 3 in the ulna, 2 in the sacrum, and 3 cases in the iliac bone. So as we can see here, our cases were almost distributed all over the skeleton. We have results from microwave ablation of bone tumors from almost all over the skeleton. There are many advantages of microwave ablation of bone tumors that we have noticed in the last 3 to 4 years of experience. Of these examples are the light-weighted and short-length needles, and this will have a very positive impact on the results of our cases, as we will see in our illustrative cases. The microwave ablation is not affected by tissue sharing. We can have a predictable, well-defined, and uniform ablation shape and size when we perform microwave ablation. As we all know, there is no risk of ground pad burns. We do not use ground pads during microwave ablation. It's fast, and we have noticed there is faster recovery after we perform microwave ablation for cases of bone tumors. The light and short needles, as we said, the most commonly used microwave needles are the 16 gauge, 10 centimeter, 3 millimeter active tip electrode. Also, we can use the 18 gauge, 7 centimeter, 3 millimeter active tip electrode. We can also use the 11 millimeter active tip electrode, and all these depends on the size of the lesion, the location of the lesion, and its proximity to important structures. And as we said again, this very light, weighted, short length needle, easily handled, is very helpful to be maintained in a stable and steady position within the bone tract and within the small lesions, the small nidus like osteoid osteoma, as we will see in our cases. Ablation with microwave is not affected by tissue scarring, especially in the very small osteoid osteomas, for example, located in the tibia or in the femur shaft. And this is unlike RF ablation. There is no rise of impedance by tissue scarring. There is no interruption of the procedure. We can perform a smooth, steady procedure with very short period of time. When we use the appropriate protocol of microwave ablation, which is determined according to the size, the shape, and the location of the lesion, we can have a uniform, very predictable ablation shape and size, and this is very important to ensure successful and adequate and safe ablation concerning the surrounding structures. This is very important to have a strict and well-defined protocol of ablation that depends on the size and shape of the lesion. And shape of the lesion is a very important factor, as we will see. Again, no ground pad burns, no hassle of skin burn all over the procedure and after the procedure. Microwave ablation is fast. As we will see, few seconds to few minutes will be enough to ensure that the whole lesion has been ablated. And this fast ablation procedure is an important advantage for me as an operator, for the patient, and for the anesthesiologists, as most of our cases are done under general anesthesia. And we have noticed also that microwave ablation has a faster post-operative recovery in comparison to RF ablation. When we performed RF ablation for 10 to 15 years, we were noticing that patients experience full recovery after ablation within 7 to 10 days after the procedure. But when we shifted to microwave ablation, we started to notice that the patients experience full recovery of post-operatively and full disappearance of pain and full stoppage of use of analgesics within 24 to 48 hours after ablation in most of our procedures. This is an example of a well-defined protocol of ablation for a specific needle. This is the protocol of ablation for the 16 gauge 3 millimeter active tip electrode. For example, when we perform 25 seconds with 25 watt of ablation, we can be sure that we will have this shape and the size of ablation, this oval shape ablation, and this size of ablation, which is 0.5 millimeter in depth, 0.9 millimeter in length, and almost no ablation in front of the active tip of the RF electrode. So we have a very defined protocol of ablation that will give us a very predictable zone and shape and size of ablation. This will ensure adequate ablation and safe ablation concerning the important surrounding structures like nerves, vessels, tendons, skin, and subcutaneous tissue. This is an example of the 10 centimeter length, 16 gauge, 3 millimeter active tip electrode. When we perform ablation for 25 seconds for 20 minutes, we will have this oval shape of ablation. And as we can see, the ablation, the heat extends backward from the tip of the microwave electrode towards its shaft, with no extension of heat in front of the microwave electrode. This well-defined pattern will make us confident that the ablation zone will fill the whole lesion without extension of heat to the surrounding structures. There are many factors that can ensure successful and adequate ablation. These factors may include the proper patient positioning within the CT table, as most of our cases are done by CT guidance, especially putting into consideration that the patient is fully anesthetized. So the proper patient positioning from the start is very crucial to ensure adequate and safe ablation. The choice of active tip of the microwave needle and the choice of the proper protocol of ablation. The application of protective measures, either the neural protective measures or the protective measures to other important structures like the skin and subcutaneous tissue, the tendons, the blood vessels. The good knowledge of anatomy and route of access to the lesion, and the choice of the proper technique and the proper positioning of the needle within the bone tract. The preoperative planning is very important and very crucial to ensure successful and safe ablation. For example, let's see this case. This is a very well-defined osteoid osteoma in the midshaft of femur. When we use the axial images to detect the shape and size of the lesion, we can see here that the lesion is very well-defined, rounded in shape, small in size. But when we look at the coronal and the sagittal images, we can see clearly that the lesion actually is a long lesion. This is a long nidus, oval in shape. Its length was about 3.5 centimeters in craniocaudal dimensions. And there is an important rule saying that incomplete ablation of the nidus equals failure of the procedure. The whole nidus should be fully ablated. So in some cases, we may have some modifications in the way of entry towards the nidus, or sometimes, like in this case, we may perform 2 tracts of entry to ablate the cranial aspect of the nidus, and then another tract to ablate the caudal aspect of the nidus to ensure that the whole nidus is ablated. Imagine if we depend only on the axial image, we can falsely see that the nidus is only very small and rounded, but actually we should see the whole images, the axial, the coronal, and the sagittal, to have full knowledge about the exact shape and size of the nidus before calculating and before determining our protocol of ablation. Another example of the important patient positioning, this is an example of osteoid osteoma located in the coronoid process of the ulna. To ensure a steady and stable position of the microwave electrode within the nidus of this patient, we had to put the patient in the prone position, and I do not use a coaxial approach. I gain access to the nidus using a bone biopsy needle or drill, and then I remove the bone biopsy needle and I reintroduce the short length, light-weighted microwave electrode along the tract I have made by the bone biopsy needle or the drill into the nidus. As long as the microwave electrode is short and light-weighted, it could be easily maintained in a stable and steady position within the nidus, as in this case. Another example of a superficially located nidus of osteoid osteoma in the talus, in the foot, the proper patient positioning on the CT table, and putting into consideration that we have the lesion is very close to the skin and subcutaneous tissue, there are tendons, there is a dorsalis pedis artery traversing here nearby, we have to introduce the microwave electrode safely and effectively into the nidus. We can perform hydrodissection to protect the skin and subcutaneous tissue from extension of heat. We can apply ice cold packs on the patient's skin all over the procedure to be sure that the skin is cool all over the procedure. And we have to choose the appropriate protocol that will ensure that only the nidus is ablated without extension of heat to the important surrounding structures. This was the final position. Again, I introduce a bone biopsy needle to gain access to the nidus, and then I remove it and I reintroduce the microwave electrode directly into the nidus. And as you can notice here, the easy handling of the shaft of the microwave electrode, it's held like a pen. This easy handling helps us to perform fast and safe and easy procedure, as we can see. You can notice here, this is a line defining the tract of the dorsalis pedis artery. So we can use here ultrasound or Doppler examination during our preoperative planning to be sure that we are gaining access to the nidus away from the dorsalis pedis artery in this case, for example. The neuroprotective measures should be promptly used when we perform ablation of spine tumors. This case, for example, of osteoid osteoma in the sacrum in close vicinity to the nerve root here. We have to protect the nerve root using hydrodissection by mixture of glucose, lidocaine. Sometimes we can mix it with small amount of contrast agent to be sure that the whole mixture of hydrodissection is located in the epidural space. Sometimes we can use room air. And after we make a protective film between the osteoid osteoma and the nerve root, we can easily insert the microwave electrode either in a perpendicular direction or in an oblique direction to ensure that the whole nidus is covered by heat safely and effectively. There are many challenges when we perform microwave ablation of osteoid osteomas. One of these challenges are the shape of the nidus, as we said before. Incomplete ablation of the whole nidus equals failure of the procedure, as we said. This is an example of an oval-shaped nidus located in the radius. The whole nidus should be covered by the microwave electrode. The whole nidus should be covered by heat. So in this case, we had to place the nidus in an oblique craniocaudal direction. We have to place the microwave electrode in an oblique craniocaudal direction into the nidus to ensure that the whole nidus has been covered. The challenge here is how to maintain the microwave electrode in a stable and steady position within this superficially located nidus in the upper limb. This was the final position of the microwave electrode. We did not use a coaxial approach. We gained benefit from the lightweight and short length of the microwave electrode to be placed in this oblique craniocaudal direction covering the whole nidus. Another example of small nidus of osteoid osteoma in the fibula, if we look only to the axial image, we can clearly see that the nidus is very small and rounded in shape. But when we see the coronal image, we can see that the nidus is actually long and oval, and the whole nidus should be covered to ensure total ablation of the nidus. So we had to introduce the microwave electrode in this oblique craniocaudal direction to cover the whole length of the nidus. Again, this was the final position of the microwave electrode within the nidus in an oblique craniocaudal direction. Again, I want you to notice in these two images the easy handling of the microwave electrode. It's as if we are holding a pen, and this easy handling makes the procedure delicate, easy, fast, and safe. The neuroprotection is not only considered in the spine. We have to know the anatomy of nerves all over the body wherever we are going to do ablation. In this case, for example, this is an osteoid osteoma of the scapula. In this case, you can see the white lines of our calculations and the patient positioning in a prone position to gain access to this nidus. After doing our calculations, after reviewing the axial, coronal, and sagittal images, and after detecting the exact size and shape of the nidus, we decided to perform ablation by 30 watt, 40 seconds, 3 cycles of ablation, then 2 cycles, 30 watt, 30 seconds. This will give us this shape and size of the nidus, this oval shape and this size of the nidus. But we have to put into consideration that this lesion was very close to this yellow circle of the suprascapular nerve. Now, we can see the red circle of the shape of ablation. We can see the yellow circle of the suprascapular nerve. There is no extension of heat to the site of the suprascapular nerve. There is no passage of the microwave electrode again against the suprascapular nerve, so there is no risk of thermal, no risk of mechanical injury to the suprascapular nerve. We have also to avoid osteonecrosis and osteomyelitis when we perform ablation of osteoid osteoma in the long bones. This case, for example, an osteoid osteoma located in the lateral aspect of the tibia. When we do our calculations and when we determine the tract of entry towards the nidus, we have to put into consideration this nutrient artery. The bone biopsy needle, the drill, should not pass through the nutrient artery because any disruption of the nutrient artery may result in remote osteonecrosis of bone. So finally, this was our final position of the microwave electrode within the nidus, away from the nutrient artery. And this will reduce the remote risk of osteonecrosis and will reduce also the risk of osteomyelitis. Let's see some of our cases. This was a case of osteoid osteoma. When you see the axial image on the left side, it's very rounded, well-defined, small in size, located in the posterior aspect of the neck of femur. But when we review the sagittal and the coronal images, we found that the nidus is actually long and oval in shape. In this case, the whole nidus should be covered by the microwave electrode, and the protocol of ablation should cover the whole length of nidus to ensure adequate and successful ablation. So in this case, we decided to introduce the microwave electrode in a craniocaudal direction towards the nidus. We will see this in the next video. Now, you can see that the microwave electrode will start attacking the nidus from cranial to caudal aspect. As we can see, here the microwave electrode comes cranially, downward, 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 and the whole nidus has been covered in an oblique craniocaudal direction. And now, in the sagittal images, we can see that the microwave electrode comes from cranial to caudal direction and covering the whole nidus. So it's an 8x7 by 13 millimeter nidus that has been totally ablated by 3 cycles. Each cycle is 35 watt, 40 seconds each. So a total of 2 minutes were only enough to perform total and adequate ablation of this nidus. Another small nidus in the tibial shaft. It was only 4 by 5 millimeter, but it was very close to the skin and subcutaneous tissue. We have to use a bone drill to gain access to the nidus, and then we remove the bone drill and we reintroduce the microwave electrode directly into the nidus. Sometimes we use ultrasound guidance to see the exact hole made by the bone drill to introduce the nidus within the bone, within the tract. We performed 4 cycles in total. Each cycle was 15 seconds, 20 watts. Another 2 cycles, 25 watt, 15 seconds. In this case, as we can see, the nidus is very close to the skin and subcutaneous tissue. We use hydrodissection to protect the skin and subcutaneous tissue, and we use ice cold packs on the patient's skin all over the ablation procedure. This was the case we have shown before in the scapula. We used 3 cycles, 30 watt, 40 seconds each, then 2 cycles, 25 watt, 40 seconds each to ensure total ablation. So a total of 3 minutes were enough to ensure total ablation of the nidus. Another small nidus in the mid shaft of femur, it was only 5 by 7 millimeter. We used the continuous mode. We made 3 cycles in total, 2 cycles, 30 watt, 15 seconds each, then 1 cycle, 30 watt, 25 seconds each. A total of like 1.5 minutes or 2 minutes were enough to ablate this whole nidus. This was a big nidus, bizarre in shape. As we can see, it looks like a heart-shaped nidus located in the neck of femur. It's about 2 by 2 centimeter. It could be considered a giant osteoid osteoma or osteoblastoma. 4 cycles were used, 2 cycles, 30 watt for 3 minutes each, then 2 cycles, 30 watt for 1 minute were enough to ablate the whole nidus, and we had to introduce the microwave electrode into two different plans to ensure that the whole nidus has been ablated from its cranial aspect to its caudal aspect. This was another challenging case of osteoid osteoma superficially located in the fibula. Why it was challenging? Because we have to put into consideration that the deep peroneal nerve is located here. So the track of entry and the protocol of microwave ablation should put into consideration the position of the deep peroneal nerve. This will define a tract of entry towards the nidus, and 4 cycles, 25 watts for 15 seconds each, a total of 1 minute, followed by additional cycle for 20 seconds, so 1 minute and 20 seconds to ablate the whole nidus. This is the deep peroneal nerve, and it's totally away and safe from the yellow circle oval-shaped zone of ablation of the nidus. Now we will discuss the metastatic bone tumors, the role of microwave ablation in the metastatic bone tumors. As we know, the skeletal metastases happen in 70% of patients with prostate and breast cancer, 20 to 30% of patients with lung and kidney cancer, and 10% of patients with colorectal, pancreatic, ovarian, liver cancer. So the metastatic bone tumors are very common, and we can see them frequently in our daily practice, and they may be complicated by extreme pain, pathological fractures, and decreased patient mobility. What is the aim of thermal ablation of metastatic bone tumors? The primary aim of ablation is to control and to reduce pain as much as we can. So it's mainly a pain management. How does thermal ablation relieve pain for metastatic bone tumors? Through many mechanisms, including the physical destruction of the sensory nerve fibers within the tumor by the intense heat, the mechanical decompression of the tumor volume after ablation, decreased production of cytokines when we transform the tumor from active to dead or necrotic. And when we combine it with cementoplasty, this prevents the development of painful micro and macro fractures. This is an example of metastatic bone tumor in the ischium, and the directly applied microwave into the metastatic bone tumor. After ablation, when we perform CT images, we can see the air foci, the hypodense air foci covering the whole tumor, indicating good and adequate ablation. And in these patients, in most of cases, pain is totally relieved within 7 to 10 days after the procedure. Another case of a very small metastatic tumor located in the coccyx. This male patient has surgically resected rectal carcinoma and complaining of solitary coccygeal metastasis with persistent pain that prevents the patient from sitting properly. This case, this very small metastatic bone tumor, we have the posteriorly located skin and subcutaneous tissue, which are at risk of thermal injury. And we have also the anteriorly located rectal wall, which is at risk of thermal injury. So we have to protect the skin and subcutaneous tissue by hydrodissection, by ice cold packs all over the procedure. And we have to do a pre and peri-operative hydrodissection in the precoccygeal space to protect the rectal wall from thermal injury. After we do the protective measures, we can now apply the microwave electrode directly into the small osteolytic lesion. And this was the post-ablation air foci within the tumor site. This patient experienced total relief of pain 1 week after the procedure, and he could sit properly again after the procedure. One of the questions we face in our daily practice, can you do ablation of large metastatic bone tumors? Yes. Again, what is the aim? The aim is pain management. The aim is to reduce or to control pain. This very big lesion could be ablated by microwave ablation. We used here a combined CT and ultrasound guidance. As we can see, the lesion could be the soft tissue mass could be easily seen by ultrasound. And the most important to relieve pain is to apply the microwave electrode at the sites of soft tissue bone interface. These are the most painful sites in metastatic bone tumors. These are the sites that carry out the sensory nerve fibers that should be destroyed by microwave ablation. So in this case, our aim was not full ablation of this large tumor size in one session, but the aim was to reduce pain. So we introduced the microwave electrode at the sites of soft tissue bone interface, and we perform ablation according to the size and extension of the tumor, again after doing our neural protective measures of the nerve root and spinal canal located anteriorly, and the skin and subcutaneous tissue located posteriorly. And this was the site of entry of the microwave electrode. This was another site attacking again the soft tissue bone interface within the tumor, and we performed the microwave ablation. This was the CT image after ablation. We can see now the air foci everywhere within the tumor volume, indicating the sites of coagulative necrosis and the sites of ablation. So in conclusion, we can conclude that microwave ablation is a fresh, new player in the field of thermal ablation of bone tumors that carries promising and interesting capabilities in both benign and malignant bone tumors that can help the team manager to win the game. And finally, I would like to express my deep thanks and gratitude to my amazing and very competent assistant, Dr. Basma Saadi, who is helping me a lot in the last 3 years of doing microwave ablation of bone tumors. I would like to express my deep thanks and gratitude to her. And thank you. Now we can see the questions in the chat box again. Okay. We have first question, all cycles in single session. Yes.
Yes.
Yes, when we perform ablation of osteoid osteoma, yes, we do all cycles in a single session. As we have seen in our cases that we may perform from 3 to 5 cycles maximum, and each cycles will be few seconds, 30 seconds, 40 seconds. So a total of 2 or 3 minutes maximum are done in the same session to ablate the whole nidus. Yes, we do all cycles in the same session. In metastatic bone tumors, we can, if it's a very large metastatic bone tumor, we can do ablation in separate cycles, 2 to 4 weeks apart, but this is rarely done. Another question, what is your consideration on determining how many cycles you need or how long the duration of each cycle? Well, at the start of our practice, 3 to 4 years ago, we were not sure of how many cycles are enough to ablate the whole lesion. So we used a big number of cycles, maybe 4 to 5 cycles per lesion. But nowadays, I only use 2 or 3 cycles are enough to ablate the lesion. And this is fixed. In all cases, I only use 2 or 3 cycles maximum to ensure that the whole lesion is ablated. Another question. How do you determine the dose of each lesion? Yes, as we said before, we have a well-defined chart of ablation, including the timing, the power of ablation, and the size and shape of the lesion. So we make full calculations concerning the size of the lesion, its shape, its proximity to surrounding structure, and according to the size and shape of the lesion, we go back to the chart. There is a separate chart for each needle size and type. We go back to the chart and we choose what is the time and what is the power of microwave that should be used to ablate this whole lesion. We do 1, 2, 3 cycles with 10 seconds or 10 to 20 seconds in between. Then we stop and we follow up the patient. How do you monitor the ablation zone using CT? Well, if I can understand this question, before starting ablation, we do calculations regarding the size and the shape of the nidus. And after determining the size and shape of the nidus, we can choose the power and the time of the microwave protocol. If your question is asking about the ablation zone post-ablation, after microwave ablation, in the very small osteoid osteomas, we cannot see the very small air foci within the nidus indicating successful ablation. However, in some cases, if we do CT, non-contrast CT examination, like 30 minutes or 1 hour after ablation, sometimes we noticed that there is a change of density of the nidus 1 hour after ablation in comparison to before ablation. Maybe 1 hour after ablation, the nidus appears a little more dense in comparison to its density before ablation. What is size criteria of nidus to determine perpendicular or oblique course of antenna? I think it's a shape criteria rather than a size criteria. The oval-shaped nidus, the nidus should be measured in all directions, in the axial, in the coronal, in the sagittal, to determine the 3 dimensions of the nidus. So, according to the shape of the nidus, the 3-dimension size are calculated, are determined, and according to the 3 dimensions of the nidus, we determine the course of insertion of the antenna, either perpendicular or oblique, craniocaudal or caudocranial, and we determine also the protocol of ablation. Go to another question. How will you remain the bone hole after drill? How do you remember maybe the bone hole after drill? How do you get back to the bone hole after the drill? Well, after I remove the bone biopsy needle and after removal of the bone drill, in our very early cases, like 20 years ago, it was difficult, very difficult to reintroduce the electrode of ablation again into the tract. But maybe after 20 years now of experience, this became much more easier to define the tract of entry towards the nidus after removing the bone biopsy needle. But nowadays, as I said in our presentation, sometimes we use ultrasound guidance to determine. You know that the cortex, the bone cortex, appears as a white line in ultrasound, and the hole made into the nidus, towards the nidus by the bone biopsy needle or the drill, appears as a black dot within this line, this cortical white line. So I use ultrasound, and when I see this black dot, this indicates the hole, so I can reintroduce the microwave electrode guided by ultrasound directly into the hole. And when I do CT images, I can see that the microwave needle is in the hole. Again, we can see other questions. Let's see, what is the last question? Okay. What is size criteria of nidus to determine perpendicular or oblique course? We have answered this question. Thank you too. Do you use cannulated screws for bone drilling? No. No, I use blunt screws, and then I remove them and I reintroduce the lightweight. Again, why I do not use a coaxial approach? Because let's imagine with me when I have a bone biopsy needle into the nidus, and then I reintroduce into the bone biopsy needle the microwave electrode into the nidus, and then I pull back the bone biopsy needle away from the active tip of the electrode to avoid any extension of heat to the skin and subcutaneous tissue. This coaxial mechanism will be very heavy to be maintained in a stable and steady position within the nidus. I only need the light-weighted, short-length microwave electrode to be only placed into the nidus. If I place a bone biopsy needle and then a microwave electrode within, I will be afraid that this could break when the CT table comes and behind doing the images. Thank you too. Uh, is drill important for access? Well, when we perform ablation of bone tumors, we have all equipment to be in place. Okay, so in most of my cases, I do access with bone biopsy needle, but in some cases, with a very extensive sclerosis overlying the nidus, like in cases of the tibia, cases of the mid femur shaft, some cases in the radius or ulna, some cases in the fibula, I have to use a drill to gain access to the nidus, but I should use it cautiously with the appropriate screw, not to perform any mechanical injury to the tendons, nerves, or blood vessels. I do not use Murphy bone gun. No, I do not use Murphy bone gun. I use just simple bone biopsy needle to gain access to the nidus. Do you keep the tip at nidus or anterior to it? Again, we say that the heat from the active tip of the microwave electrode goes from its tip backward. So the tip of the microwave electrode should reach the end of the nidus, or even we can transfix the nidus to ensure that the whole length and the whole depth of the nidus is ablated. Another question, the best option to protect the skin during drilling. How to protect the skin during drilling. If your question is about only drilling, how to protect the skin during drilling, by the use of the appropriate drill screw. I should not use a very big screw to injure the skin. A thin screw will be enough, but you should use it cautiously. And the power of drilling should be not that big or heavy power. You should do gentle drilling with a medium power to avoid injury to the skin and to muscles. If your question about how to protect the skin during ablation, if the lesion is very proximate to the skin, I do hydrodissection using a mixture of glucose or saline together with lidocaine, with application of ice cold pack on the patient's skin during ablation and 5 minutes post ablation to protect the skin from any heat extension. Is the sequence bone drill, biopsy, and antenna? Yes, but biopsy if indicated. In most cases of osteoid osteoma, it does not need a biopsy to be sure of the diagnosis because it's well diagnosed by its radiological and clinical criteria. If we have a well-defined nidus, rounded or oval, less than 1.5 centimeter in diameter, causing pain, increases at night, and the most important, awakens the patient from deep sleep in the late night and relieved by continuously increasing doses of aspirin or analgesics. This is an osteoid osteoma that does not need a biopsy. But in some cases of bone metastasis, the oncologist requires to do a biopsy before doing microwave ablation, so I do biopsy. In cases of chondroblastoma, if the lesion is big with cortical defect, I prefer to do a biopsy before doing ablation to be sure of the diagnosis. In large metastatic bone, how much size regression is considered? Okay, the size regression that could be considered successful if the patient comes after few days, 7 to 10 days, telling us that the pain has been reduced. So it's not important to do a size regression. It's important to relieve pain in these cases. And size regression will be proportionate to pain relief because one of the mechanisms of pain relief is the debulking of the tumor volume. Bone fractures can happen during drilling. Theoretically, yes, but all over the last 20 or 21 years, no fracture happened in any of our cases, either during drilling, during ablation, or thereafter. And again, I say, and yeah, you should be cautious when you do bone drilling to gain access to the lesion, and you should use the appropriate screw. You should not use a very big screw, and you should use the appropriate power of drilling and the appropriate velocity of screwing. Again. Okay. If lesion in contact with nerve, as we have shown in cases of the sacrum, cases of the scapula enclosed to the suprascapular nerve, the good knowledge of the nerve trajectory is very important, and we have to protect the nerves by using hydrodissection, or even sometimes we can inject air in the epidural space to protect the nerve from heat. And the direction of application of the microwave electrode should put into consideration the presence of nearby nerve. Well, regarding the friction of drills, yes, again, another question about drilling. The appropriate screw should not be of a big size. The appropriate power of screwing should be considered. Fluoroscopy can be a guidance? No, I don't like fluoroscopy as a guidance. I only use CT guidance. I do not use fluoroscopy alone as a guidance. I use CT, and I may use ultrasound as a guidance also. Okay. Any other questions?